Hello, fellow zebra hunters. Welcome to an episode of Diagnostic Atypia, an open book podcast where we work and sometimes stumble through real life clinical cases with diagnostic twists and surprising endings. I'm Mike Arcieri.
And I'm Andrew Sanchez.
And we're residency friends who are now brand new hospitalists fresh out of residency.
That's right, Mike. Podcast, attending life, it's all new to us. Anyway, I think we've got a great episode for you today. So whether you're commuting to work, cleaning your apartment, out on a run, or one of the few who listen to podcasts without multitasking, thanks for tuning in and let's get started with another atypical journey.
Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed in all episodes is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant with key identifying details changed.
Where is he? There he is.
There he is.
He's just out.
Yeah.
That was just Andrew showing me his dog, who's now a third guest on the show.
Official sponsor.
Official sponsor.
No, we were just talking about we're feeling more machine-like with the episode production, which is great. We're in a nice flow of things. This is actually our third recording for the week after a long hiatus. Did I add a number? This is our third recording. Yeah.
It's our third.
Yeah, this is our third. So we are a machine, and I'm going to present a case to you of the machine failing. This is...
What a good intro.
I know I was hoping the record button was on earlier. Would have been a perfect, smooth introduction. Still smooth. This is a case from early attendinghood, actually, maybe like a month and a half in on service. And it's the case of a man in his 30s who had a BMI of 44, but who otherwise had no known past medical history, who presented for falls. He lives in an apartment with stairs. In the evening prior to presentation, said he began going upstairs and almost made it to the top of the flight when he felt his knees buckle. After crawling up to the floor using his hands, he tried to get up several times but couldn't. He isn't able to explain precisely why, but he summarizes it as, quote, knee buckling, happening over and over. Regarding other review systems, he described new numbness and tingling in the feet. He has chronic low back pain with active lumbar discomfort the last 2.5 months. He has no urinary or fecal retention or incontinence and no saddle anesthesia. So his CBC showed anemia with a hemoglobin of 12.8, an MCV of 92, a high RDW of 20, no other cytopenias. His BMP was completely normal. And just to give you some context, this guy was admitted specifically for an MRI of the spine per a neurosurgical consultant's recommendation. So what this means is that when you meet this patient, the only lab studies you've got are the ones I just gave you, and you basically get free reign over what you want to do in the entire case because he's on the floor and he's just kind of pending workup. So yeah, what are your first impressions? Just open book here.
Do I get the MRI findings or just that's outside hospital and they still need to be faxed over?
This guy is just waiting around. Actually, because of his body size with a BMI of 44, it requires a special machine. So it's going to take quite a while for that to come back.
I see. So he's waiting for an MRI. That's why he's admitted.
That's right.
Not because of results. I understand.
That's right.
Great. So a couple thoughts. To start, I think falls are one of those conditions that are really framed by the age and the past medical history, as well as sort of the history itself. So I'll go through each of those. Really kind of think about falls as falling into, no pun intended, 3 buckets. And essentially these are all right things that just cause a person to fall. It's gravity is winning, right? So there's 3 major ways. One is that there's a true loss of consciousness that precedes the fall. Remember, people can show up with a fall and loss of consciousness, and it can be unclear if it was before or if they had a head strike and then lost consciousness. But losing consciousness, right? You're losing postural tone will bring someone down to the ground, and that is a definition of a fall. And so that really is syncope, pre-syncope, and that has its differential that we sort of, I think, talk about all the time in internal medicine. The second bucket is what I like to call the slip, trip, and fall, which is someone who may have no inherent past medical history or predisposition to falling, but finds himself in a situation such as a rocking boat or ice on the ground, slippery floor in a grocery store, or they're intoxicated, which will actually fall into a little bit into the third category. But they in a way are just mechanically falling, and but for this thing that they encountered, they wouldn't otherwise fall. And then the third category, and I think the one that we're often tasked with, and which is challenging because it's broad, is disorders of, I'm going to lump three things together, the sensory neuromuscular axis. So basically, what is involved in gait and walking and standing is you need inputs, right? So you need proprioception. That involves three things. It involves sensory inputs from the peripheral nerves and joints, tendons. It involves vision, and it involves hearing and the vestibular complex, right? So that's what's involved in just sort of knowing your place in the world and being able then to adjust to changes so that you don't fall. You then need a processing system, right, that can take that information, the inputs, and is able to sort of decide where you are in space and account for changes that may involve in falling, right? And then sending out the information about how the muscles should adjust to this. And this happens both in the spine, right? We have these reflex arcs, as well as the central nervous system, the brain, excuse me. And when we talk about the brain, we're talking about the motor cortex, the sensory cortex, the basal ganglia, the cerebellum. And then lastly, you have the outputs, right? You have the signals that go out from the brain and tell, and the spine, and tell these muscles and joints and tendons what to do in order to account for this change in balance, propensity to fall. And so for that, you need, of course, a working brainstem, working spinal outflow. You need working nerves, nerve roots, peripheral nerves, neuromuscular junction, and then muscles themselves, right? You need all of those things. So all three of those systems have to work all together in order to keep a person upright, even if they're conscious and even if they're not falling on some sort of slippery surface. What you'll find is that as we get older, there are more and more things that get loaded on to these issues, all three of them, really, right? You start to accumulate past medical history and just sort of inherent risk factors for falls, which is why a person who's admitted with falls who's in their 80s and 90s is a very different admission than someone who is having falls in their 30s, because by the time you're in your 80s and 90s, we know just sort of physiologically we tend to lose some muscle mass. And additionally, right, we have sarcopenia, which can accelerate with age, and so frailty. And then people develop things like peripheral neuropathy and strokes and cognitive deficits. And so all of these things, and medication, right? Medications that impair the cognition, the central processing part of things. So all of those things are going to get there's more opportunities for those things to get loaded with triggers as you get older. In a young person, which is often the case in many clinical reason exercises, right, is that it oftentimes is more likely to be one thing rather than a combination of risk factors all kind of accumulating in the perfect storm. And some of those things really aren't going to be found in young people, except in very rare cases, right? Dementia, really not going to be very common. Sarcopenia, not seen with, great regularity in young people, notwithstanding genetic conditions and more rare examples. And so, the young person then with falls, the history is really what's important. So is this someone who has had falls for years and it's slowly progressing? Is this someone who was fine a couple of days or weeks ago and now all of a sudden develops more acute falls? And then what other things are going on? Is this a person who has pain that's new or sensory loss that's new? Are there certain activities that cause them to fall, such as going up and down stairs, whereas walking on the flat, there's no issues, right? Which gives you some ideas about what muscle groups might be involved. There's a lot more than that, but I'm just going to stop there for the sake of time. And I guess my question would just be to sort of clarify history in terms of tempo, and if this has ever happened before. I think that's probably the place I would start.
Wow. My comment is in my reflection is clearly falls can be so complex, but I feel like you made it so simple. I love that approach of syncope or no syncope, loss of consciousness or not. The slip, trip, and fall, is that what you called it? I love that term. And then the neuraxis. You've just made it so simple. Thank you, Mike. I think that's a really, really beautiful way of thinking through the problem of falls. So I'll give you some information to satisfy your need for history here. And just on tempo first, this is a guy who's never had this sort of issue before. So the first event was he was climbing the stairs and then his knees were buckling. And then when he got up, it just happened over and over again. This had never happened to him before. So you go and meet him at the bedside, and he said that the numbness and tingling in his feet began about 24 hours before coming in. And he thinks now it has spread to his knees now bilaterally. And on your exam, he has no pronator drift. He has at least 4+ out of 5 strength in the bilateral hips and leg extensors, and 5 out of 5 strength in the bilateral dorsii and plantar flexors. He has issues with reliable proprioception in both of the great toes. When you touch an ice cube to his feet and hands, he has immediate cold sensation bilaterally. He has intact gross touch sensation in the toes bilaterally, and heel to shin and finger to nose testing is normal bilaterally. His extraocular movements are full, and he has no diplopia on sustained lateral gaze, and he has no ptosis. And that's really it. That's his history. And this all started, again, really within this 48-hour window. So how does the history and exam change how you're kind of framing this patient's falls?
Perfect. So I think the first two buckets, right, are now sort of low concern. This is not someone who lost postural tone and passed out and fell. This isn't someone who found themselves in a situation where most people would fall, the legal fall, slip, trip, and fall. So this is something that I think you said the neuraxis, which I really like that term. It's more eloquent than my combination of various systems into one word. So let's call it neuraxis. So it sounds like this is the neuraxis, and specifically, you're telling me that there are really signs of polyneuropathy, right? Because he has weakness, but he also has sensory loss, right? And changes in proprioception. So you're hitting multiple different types of nerves in order to get that syndrome. And it sounds like there's some relatively good strength, but less strength in the proximal muscle groups than the distal muscle groups. And the other question you were sort of asking is questions of, is this thing ascending, or is this sort of a system? You mentioned the ptosis and the upward eye gaze, right? Is this something like myasthenia? But it sounds like now we're kind of thoroughly in the neuraxis camp, and probably more peripheral nervous system rather than central nervous system, right? Because you're also mentioning there's no cerebellar concerns, no cognitive concerns. Doesn't sound like he's intoxicated or was intoxicated during this episode. So it sounds much more peripheral. And then the fact that it's begun in just a couple of hours to a day tells me this is probably something acute. And based on localization, it sounds like this is something that's probably going to be around the lower spinal cord, spinal nerve, somewhere in there is, I think, where this is probably going to localize too. In terms of labs, I think, anytime you see proximal weakness, it's probably good just to think about myopathy. Tends to be more painless, but, sending the basic workup for that, which is going to involve, in a young person, especially someone who's quite obese, or thyroid disease can cause myopathy. B12 deficiency does not cause it this quickly. Not certainly a person of this age also would be unlikely. A CK, right, would be helpful, because if it's really, really positive, then that pushes us much more towards something that's myonecrotic or myoinflammatory. So TSH, CK. I don't know that we have liver enzymes. If we do, I think they might have been normal. If we don't, that'd be something helpful to have. And ESR CRP also could be helpful, again, because it can help rule in something inflammatory, right? It may not be helpful in someone who has a lot of chronic conditions in their 80s and 90s, but in the 30-year-old who sounds like he was pretty healthy before this, he may have a mildly elevated CRP-SR from the obesity, but I wouldn't expect it to be super high, and it would change management. And then it does sound like it localizes to the either the spinal nerves or the spine. So I agree with MRI, which sounds like is the reason he's here. And so I'll stop there.
Oh, I love that so much. So can't miss myopathy, easy screen. We're still thinking about the spinal cord just because that was the presenting concern, but sounds like thinking more peripheral nerves at this point with the sensory issues. My exact thoughts too. So you send off all those blood tests, and those are gonna cook for a little bit because again, this guy was admitted just for the MRI and nothing had been sent. So you send those. You go back to your computer and start to write notes. You get a text from the nurse saying that when he worked with PT earlier in the day, the patient had an episode of tachypnea and anxiety that he cited as due to pain related to a Hoyer lift. The nurse isn't very concerned, saying it looked pretty scary, but it completely resolved when he got back in bed a few minutes later. And later in the afternoon, you go back to PM round on him and you meet the patient's brother, who's an EMT, and he agrees with you that patient's looking slightly tachypnic at rest. Although when you ask the patient, he doesn't notice any discomfort. You go back to your desk and then come back a few hours later, and now you find him sitting upright at the edge of the bed, feeling sweaty and uncomfortable. He doesn't know why, but says he feels much better sitting at the edge of the bed and with his legs dangled over. I send a VBG. It's a normal pH, normal PCO2. I go home. When you come back the next day, the handoff mentions a rapid response was called overnight. The rapid note says the overnight hospitalist was called for the patient being found sliding off of his bed, and he was kind of half off the bed. He was found tachypnic and diaphoretic, and as the history was being taken, he was initially responsive, but then lost consciousness and slid completely off the bed. His heart rate dropped to the 40s, and he desaturated on room air to 70%, and they said he was shaking and very diaphoretic. A non-rebreather was placed, which improved his saturation, but he was still very much non-responsive. They hoyered him back into the bed, and after putting him at 90 degrees upright, he regained consciousness to his baseline within 10 minutes. When he regained consciousness, he said that he fell out of bed and was using every ounce of the strength in his body to basically hold on so he wouldn't fall off. And he says this kind of led to a vicious spiral of breathing difficulty. A VBG acquired during this episode showed a still normal pH, but a newly elevated PCO2 to 50. So now it's the morning after. The patient tells you he's feeling better from the night before, but now you're kind of worried. So you make sure to check on him a few times during your shift. And sure enough, I end up having to write a new rapid response note, which I'll read word for word. Today in the afternoon, I found the patient lying at 30 degrees on his side. He was tachypnic, but not in extremis. Mid-conversation, his eyes rolled to the back of his head for a few seconds at a time, and he was inattentive. I told him I was concerned about him and he needed to sit up to 90 degrees. He subsequently tried to swing his legs to sit upright at the edge of the bed, but due to group concern, we would not be able to support him in this position. We tried to sit him back in bed. He tried to resist this and subsequently continued to lose control of his respiratory rates, eventually falling limp and becoming unresponsive. His eyes rolled to the back of his head persistently, prompting me to call a code. His pleth waveform was poor and read in the 60s. One RN got a positive pulse, so he never lost the pulse. We hoyered him back to 90 degrees, placing him on a non-rebreather again, and his saturation improved. And then over 10 minutes, again, his respiratory rate, mental status, and work of breathing improved in the 90-degree position. Another VBG was sent, and now the pH was low at 7.30, and the PCO2 was increased further to 62. His limb strength is the exact same through all of this. So he's still generating at least 4+ out of 5 strength in the bilateral hips, and he's otherwise 5 out of 5 strength elsewhere. So what do you think is happening here? And what are some management contingencies you're thinking of now that these episodes keep happening?
Yeah, this is much scarier now, obviously. So interestingly, it sounds like what he was initially describing is maybe orthopnea, right? He's having to sit up at the edge of the bed. That makes him feel better, and then efforts to lay him back down. He's feeling anxious or tachypnic. That's can be a clue that someone has orthopnea, right? Because oftentimes breathlessness does create a sense of anxiety, and then sometimes the anxiety then leads to tachypnea, which may actually exacerbate whatever the underlying process is. So you can get, like you said, a kind of a vicious cycle there. But then, he does actually have sort of progressive hypercarbic respiratory failure, right? And an altered mental status that's unclear whether the altered mental status is driving the hypercarbic respiratory failure or whether it's secondary to it. It's probably a component of both, I'm guessing. So, I mean, I think this is a guy who now, just based on the history, I'm trying to kind of put these two things together. So, hypercarbic respiratory failure, it's I can't breathe or I won't breathe, right? So either you won't breathe because you don't have a respiratory drive, or you can't breathe because you don't have the strength in order to overcome whatever resistance there is, whether that's normal resistance or whether that's some sort of higher resistance in the work of breathing. So the classic won't breathe is, opioid overdose. And so I guess there'd be a question of whether or not he got any, opioids overnight for possibly pain, maybe while he was trying to work with PT. So that's one consideration, although that should wear off and not be progressive. It should get better with time. Also, does he have, so that's won't breathe. In terms of other things that would cause a altered mental status in this guy, it really sounded like things were more peripheral, but could he have some sort of central lesion that is creating an altered sensorium and also somehow hitting various spinal tracts that I'm not going to try to remember, that could be creating the syndrome? I can't think of how that would create bilateral lower extremity polyneuropathy. Could he have meningitis and it's causing these symptoms? I don't think so. And then, so that's the won't breathe. In the can't breathe category for hypercarbic respiratory failure, I guess I would think, things that inherently increase the, decrease, the compliance. So, right, does he have like with orthopnea, does he have some sort of pulmonary edema, congestion? That's just, he doesn't have the ability to overcome that decreased compliance. That may be because he we know that if you have a lot of abdominal obesity, sometimes you sort of are breathing tachypnic at baseline, sort of similar to a patient with pregnancy, right? That, they can't take deep breaths, so they take more breaths. And so maybe he sort of lives closer to that at baseline, and then you get some edema, and then, you sort of can't compensate. Unlikely in a 30-year-old, but definitely could be possible in someone whose BMI is in the 40s. And then I think the other thing, right, would be that the lungs are just fine, but the actual neuromuscular firing of the diaphragm is impaired, like neuromuscular disorders. So could he have an ascending polyneuropathy? And what started down in the lower spine has now ascended and is involving, right, the diaphragm now, and also the accessory muscles of breathing, respiration. And, that I think is quite concerning. That's higher on my list. And then, this recurrence of eyes rolling back in the head, getting worse, and then sort of getting better and coming back, maybe fatigability. And so myasthenia would be another thing that I would be somewhat worried about, I think. And yeah, I guess the thing I would really like to know is, I actually would probably want to get some head imaging on this guy. And then additionally, I would actually like to hear if it can be very hard if someone with a BMI of 45 to really get a good lung exam. So it may actually just getting a chest x-ray to start, a BNP, just kind of like thinking about causes of orthopnea as well. If we think that maybe there was something that caused orthopnea and then it led to this hypercarbic respiratory failure, that seems to be what you're giving me is that was sort of the chronology. Probably at this point I would just send the myasthenia workup because it's just a blood test, easy enough to send. And yeah, this guy definitely, if he's not in sort of a step down area, you should be thinking, it's probably worth having much higher level of monitoring because this continues to happen and it seems like it's getting worse. I'm going to stop rambling there, and I'm sure there's more that I missed, but I'm interested to hear if any of any of those results come back, or if there's other things that you found were good to send and were helpful.
Oh, you're right on track. And called ICU triage while that was pending, got a chest x-ray, clear lungs, BNP normal. And this just kept happening. And I love your thoughts on the neuromuscular axis. So thanks for playing along, Mike. I've presented the case in this way because the acute tachypnea events, presumably from diaphragmatic weakness, inform us quite a bit on why this patient with very good strength on exam was having issues walking and breathing when lying flat, as you have accurately categorized this patient's breathing really as an orthopnea issue. So the crux of the case is really, why should someone with excellent motor strength on exam have falls and hypercapnic respiratory failure? And the answer lies in the load that the muscle is facing, which is something you commented on in the form of resistance. So for our listeners, if you imagine you're in a gym doing a bench press, which for non-weightlifting listeners involves you lying on your back on a bench and pushing a barbell straight ahead of you, you can imagine that it's pretty easy if the barbell has no weights added onto it. Now, imagine you add 45-pound weights to each side of the barbell. All right, no problem. Add 3 more plates to each side. That's 180 pounds on each side plus the 45-pound barbell. So that's a 405 pounds total. I've selected this weight intentionally because our patient recalls about 450 pounds. So hold the visual of the 405-pound barbell in your head for a minute. What are we doing when we're grading strength on the neurologic exam? Recall that a strength of 3 out of 5 is quite weak. When it's 3 out of 5, you can only lift a limb against gravity, but not offer any resistance. However, the 4 to 5 strength gradation covers a range of strength against your resistance, from weak resistance to nearly complete resistance. Bringing out weakness in this range can be very hard, if not impossible, for patients with class 3 obesity. Because think about it, that 405 barbell you're holding in your mind, can you apply that amount of force on your patient's leg when you're doing a strength assessment at the bedside? Some of you maybe can, but I can't. So the takeaway here is that even if a patient's strength is graded 4+ out of 5, or even 5 out of 5, you need to stop and question the assumption, oh, this patient isn't that weak, when you're facing a patient with class 3 obesity. And this is because they may be strong against the max force you can apply, but when they stand and have to carry their body's entire 450 pounds, the load becomes too high for that very subtle weakness deficit. So to summarize, unless you can apply that amount of force at the bedside, you're not going to observe what I call subtle weakness. So the story of this patient's recurrent acute hypercapnia and loss of consciousness from respiratory failure was the exact same story. While the patient was upright in bed, his diaphragm had the benefit of gravity, and therefore his breathing was relatively compensated. But when he began lying flatter, even like 30 degrees, as I said, he lost the benefit of gravity, and his abdominal obesity became a huge problem. So back to the case, truth be told, this whole time I actually knew the reason for the patient's weakness, because one of the blood tests that we sent the morning I inherited the patient came back in less than 3 hours. This is more presented in this way just because of how informative this problem can be, and basically the subtlety in the exam. So before I reveal the final diagnosis, this is not even a read my mind question. I'm just more curious, like thoughts from you on neurologic diseases that can present like this acutely. And you've already said some of these, so I'll just repeat some of them. Myasthenia gravis came to mind, given kind of like the fatigability. Is there anything else kind of in this tempo range that comes to mind for you? And then I'll let you know what ended up happening.
I think the other one is, acute demyelinating polyneuropathy, GBS, right? I think that's kind of classic ascending weakness that then eventually involves the respiratory centers. That's like the feared complication of GBS. So I think that's the other big one. There's a chronic form, but that's going to be greater than 8 weeks, right? So this is something that happened more acutely. This is kind of fast for that to be totally fair, but definitely this would be like the more common presentation. Myasthenia, Lambert Eaton, but he's pretty young. I don't think he has malignancy. I think those are the ones. I'm wondering what else I'm missing there.
Yeah, no, I think that's the exact reflex I wanted to elicit from you, and there'll be a teaching point made out of that. And I think before revealing the diagnosis, it's just important to say, this whole weight issue and load issue, I think that almost like alters the tempo we're ascribing to this disease process, because the weight has made this subtle weakness a really big issue. But if this guy was, BMI of 20 walking around, this probably would have been going on for more time, right? And more of like a subacute chronic even presentation, just because they could have compensated and they're not carrying around that load. So it's an interesting reflection. So this is what happened. We sent the initial metabolic screen, as we do for polyneuropathy, and as which you discussed. And within 3 hours, his B12 level was undetectable, less than 150 picograms per mil for our lab. A methylmalonic came back, in like a week at greater than 20,000 nanomoles per liter, the upper limit being 320. And his homocysteine came back high at approximately 155 micromoles per liter. And here is the kicker. It's not done. The patient had been admitted, and a family member called the nursing station saying, hey, this patient actually inhales nitrous oxide at home, and I have no idea if it's relevant to the case, but it's kind of their vice, and I think you should know about it. And I'm wondering, this is the final bonus question for you, and it's kind of a leading question. You have now nitrous oxide use, which the patient does admit to when you go ask him about it. He doesn't want to talk about it at first, but once you say that the syndrome fits, he says that he does inhale nitrous oxide a couple times a week. Are we done with the case now that we have a history of nitrous oxide inhalation, but we also have a low serum B12 measurement?
I do believe that nitrous oxide pretty classically leads to B12 deficiency. I don't know the mechanism. Let me think. I don't remember actually if there's other ways that that nitrous oxide could. I don't know if it's directly toxic to nerves outside of just causing B12 deficiency, but I'm going to say that it seems like that supports our existing diagnosis. I don't know that adds something to it.
Yeah, so here's the kicker, and there was a New England Journal article on a case of this actually quite recently. So nitrous oxide inactivates B12, but doesn't get rid of it. So your serum B12 should actually be normal. Now, because it blocks its activity, you're going to get the high methylmalonic acid and the homocysteine still. But the fact this patient has an undetectable B12 means we're actually not done. And of course, we've talked about pernicious anemia on the podcast before. We sent an intrinsic factor antibody, and I talked to GI saying, hey, if this is negative, I think this guy needs to get a scope. And sure enough, the intrinsic factor antibody came back positive, which has a very high specificity for pernicious anemia. So we were able to give him, without a scope, a diagnosis of pernicious anemia. And in talking to a neurology friend of mine, because I had never seen this before, and I wanted to make sure I was going through the right pathway, and this is why I consulted neurology. I was like, do we need to do a pernicious anemia workup? Am I correct in that he should not have a low B12? And the neurologist said, we see nitrous use all the time, and it's not uncommon just because of how pernicious anemia is that you see both. And it's honestly that double hit that makes people so prone to having subacute combined degeneration, which is the syndrome that we saw in this patient. So I want to start with 3 teaching points. Teaching point number 1, some reflections on the approach to polyneuropathy after many, many warning reports and subsequent reading. So the TLDR is, there are a lot of ways to approach it. Axonal versus demyelinating, large versus small fiber, bucket-based, like metabolic, toxic, inflammatory. And what I've come up with that I use for every new neuropathy case is instead a sequential practical approach that begins with a first pass, addressing common causes, which is basically what Mike did. For everyone, I send a B12 and methylmalonic, A1C, TSH, creatinine, and LFTs for a metabolic screen. And you need to send additional vitamins if the patient has dietary restrictions, bariatric surgery, or if there's a concern for malnourishment. So these are the B1, B6, E, and copper tests. First pass also contains a medrec for potential toxins like chemotherapy and history of recreational toxins, including not just alcohol, but also Whippets inhalation. Whippets is the street term for nitrous inhalation. So finally, the infectious culprits HIV and Lyme are common enough to test for up front. So epidemiologically speaking, this pass should cover the vast majority of polyneuropathy cases you encounter. In this case, it led to an answer in less than 3 hours. And this isn't a patient otherwise who was going to be inpatient for several days awaiting a bariatric MRI, which we did not end up performing after shared decision making. Teaching point number 2. In the world of neurology, diseases that present acutely on the order of days to weeks are most commonly due to infections and inflammatory processes like Guillain-Barré, as Mike mentioned. In neuropathy land, you should keep in mind that nutritional neuropathies actually join this list. And a neurologist who publishes a lot of great teaching on Twitter taught me this pearl. His name is Marcus Pinto, and our listeners definitely need to give him a follow. He says that B1 deficiency can sometimes mimic Guillain-Barré nearly exactly. And with the right past medical history, like alcohol use disorder, he recommends giving empiric thiamine, the rationale being time is nerve. His clever way of remembering this is sometimes IVT is better than IVIG. That said, these cases can be so tricky, and he even mentions giving both IV thiamine and IVIG is necessary in tricky cases. So I'll never forget that pearl, because in this case I presented, we got to the diagnosis and treatment in just over 24 hours, yet he still developed ascending weakness touching the diaphragm, leading to recurrent respiratory failure. So you can imagine what his clinical course would have been like if we didn't start high dose IVB12. Again, even if his axons degenerated to the point his weakness dropped to maybe only a 4 out of 5, maybe I'm being extreme, but it's not inconceivable that he could have ended up on a ventilator for a minute if we didn't kind of save those neurons in time. Teaching point number 3, this is just the perfect example showcasing how to approach non-cardiac orthopnea. And I think Mike laid that out really well. Really think diaphragmatic weakness, increased load, or a combination of both, which in this case, there was really a load issue more so than the weakness issue. That's all I got. I'm sure listeners will extract much more from this case. It's super rich. Email us if anything stood out to you. Mike, I just dropped a bomb on you. What do you think?
B12 deficiency strikes again. It's interesting because I don't think about it as something that causes an acute presentation, certainly on the orders of like a day or two. But it is a really important, like this just kind of applies to clinical reasoning broadly, right? Is like, who is the patient this is happening to? And can a more chronic subacute problem tip them over much sooner than sort of the patient that we often hear about in med school, right? Because I mean, unfortunately, med school tends to focus on a 70 kilogram white male, right? So that may be the way that a disease presents in that very specific demographic. But as you add different risk factors on, and this kind of goes back to the very beginning with falls, right? You're thinking about who am I exposing this person, who's getting exposed to this one trigger, right? And so in this case, he did actually kind of have the perfect storm of it takes a lot more muscle for him to walk, and it takes a lot more muscle for him to breathe, certainly in the supine position, right? And you throw in maybe he's got some disordered breathing, maybe he has sleep apnea, and so he goes down, gets a little bit obtunded, and then those things start to influence it, and you sort of get a vicious cycle that kind of, spirals. So I think that is probably for me, outside of the specific continuing to learn about B12 deficiency and its various causes and presentations, is just thinking about the patient in front of you, and the fact that this is how sometimes common things present uncommonly is just because of the patient-specific factors. And one last plug for physical therapy, because, and this is another, I guess, kind of broad principle, but I think physical therapy is a good example of how we can, not forget this is the case. We often examine patients laying in bed, right? Which is probably the lowest stress activity that the human body can be in, right? I mean, how many patients, if you're coming in with symptoms in bed, I mean, that's very, very severe, right? But most patients are having symptoms with sitting up or walking or, driving, exercising, right? Like they need some level of load to get the symptoms. And so I feel like all the times you'll hear like, oh, he looks great. He looks great in bed. And it's like, well, yeah, I mean, most people do, even people who are quite sick, right? Because it's like the lowest metabolic energy required. So, physical therapy, I think it's why oftentimes it happened all the time through residency and now as an attending too, right? Like a patient who you're like, oh, I think that they'll probably go home. And then you get this recommendation for short-term rehab and you're like, oh my gosh, I had no idea. I've sort of gotten in the practice of patients, particularly any patient whose symptoms that they presented with were exertional, ambulatory. I just walk them myself. And the reason at the beginning and then when I'm thinking about discharging them, because that's really what brought them in. And so if no symptoms in bed is your threshold, then you're going to miss a lot of people who have more subtle disease, or maybe not even that subtle, but right. So get your patient up, walk with them, see if their symptoms come back, put them on tele, walk with them. What does their heart rate do? Just like those sort of things. Physical therapy does that, and that's part of their evaluation. But that really tells you kind of the level of disease, I think.
Oh, beautiful reflections, Mike. I think you captured all of the important elements of the case and that final reflection. So I think we just got to stop it there. Oh my gosh. Thanks for playing along. Again, email us listeners if you have any thoughts. I think there's a lot more to extract from this case. I hope you enjoyed and have a great week.
Never forget TSH or B12.
Oh yeah, we're now a metabolism podcast, by the way. We only talk about methylmalonic acid and homocysteine going up. So if you're tired of that, maybe unsubscribe from us.
Oh, thanks so much for everyone listening. And thanks, Andrew. We'll talk again soon.
See you, Mike.
See ya. This has been Diagnostic Atypia with Doctors Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.